We exist in a world where there are just such massive inefficiencies. Even something as simple as making a lung cancer diagnosis requires comparison to previous charts, review of previous records, looking at the lesion itself. So even a simple assessment can require combing through minutes and minutes and minutes of data that an AI could do in the snap of a finger.
Hi, welcome to AI in Healthcare. My name is Mika, and I'm super excited today to be here with Pelu Tran, who's the CEO and founder of an amazing company called Ferrum Health. Before we get started, Pelu, can you tell us a little bit maybe about you and Ferrum Health? And then I have a ton of questions to ask you.
Mika, thanks for having me. It's really a privilege to be here on the podcast alongside so many other legendary names in healthcare technology. So a bit about myself. I from the great state of New Jersey, but came out to California almost 2 decades ago to go attend engineering undergraduate and then medical school at Stanford. And I started a company in 2012 coming out of medical school and ultimately scaled and built a company, bringing it public about 6-7 years later. And in that journey, I had a chance to really get to understand the deep inner workings, sausage making of healthcare, and had the experience of really realizing just how difficult it is for a doctor to use even an incredible new solution that could transform patient care. The barriers to entry and the cost of adoption was just sky high. And then towards the end of that journey, as we had this 2,000 person company and we were really gearing it up for public markets, I had a personal experience as a family member of a patient where my uncle actually passed away from a late stage lung cancer that had been missed by his doctors for over 5 years. And this was at the same time that, as a Silicon Valley founder, I personally knew the CEOs of 3 different companies that were building lung nodule AI solutions. And any one of those companies could have found my uncle's cancer multiple times over the span of those 5 years for pennies. But because his doctors just did not have access to the tools that they needed to deliver the care that was possible, my uncle passed away from a preventable medical error that really should have been caught early and really should be caught often. So Ferrum Health was founded out of that experience with the mission of trying to solve the AI adoption problem in healthcare. And our goal is for every provider and patient in the world to be able to leverage the AI tools that are on the market today to deliver the best care possible. And unfortunately, as you and anyone else in healthcare knows, we are a very, very, very long distance away from that vision being realized. But that's our mission.
Yeah. Well, first of all, I'm so sorry to hear about your uncle. I've lost family members actually to cancer as well. It's one of the reasons I started working in this field. So I feel you there, certainly deeply. So let's get this fundamental problem. Like, why is it still so hard to implement AI in hospitals? Like and I agree with you, by the way, it seems like the solution, like the only solution that's going to solve many of these problems, but it just isn't happening. What are those barriers?
As we dug into the problem, starting the company, our working premise was that the AI models just weren't performant, right? Healthcare is super conservative. They really need tools to work perfectly before they could be adopted. And we always thought that might be the issue, is that AI is just not there yet. What we discovered was that AI is there. You have AI tools for virtually every common condition now. We've maybe not fully automated, but led to significant improvements in potential rates of diagnosis and treatment for these diseases. But it's the fundamentals of healthcare IT, the fact that we're working with legacy systems that are oftentimes decades old, multi-million-dollar support and maintenance that is already taking up all the hospital IT team's bandwidth. And the fact that these AI tools are these hyper-modern, cloud-based, data-hungry solutions that are being thrust into a very, very cautious, very legacy-driven, and very technically conservative environment. So to break that apart, I think you're talking about massive multi-million-dollar costs to turn on new vendors in healthcare, to move them through all of the different committees and approvals and governance within a given health system. You're also talking about hyper-conservative policies around patient data. And really a lack of comfort with both the cloud deployments that most AI vendors deploy within, as well as the data needs that those companies have. Fears around how is my patient data going to be used if a vendor gets breached, as increasingly happens. What is going to happen to all the patient data I sent them? And then the last piece is really this patient safety issue of AI performance, where every single AI model, bar none, is biased, is going to discriminate, is going to underperform on some population, because no patient population is the same. And unlike drugs or devices, AI cannot just run a clinical trial, show it's performant, and then reliably work into the future. Right? AI shifts over time. These models are trained on certain populations, oftentimes those in Boston or New York and California, that do not resemble the average patient population that they're serving. And so these sorts of AI performance and governance issues around how are we ensuring the security of these deployments? How are we simplifying their deployments in ways that the average hospital's IT systems can digest? And ultimately, how do we actually ensure these tools are safe and governed for use in critical conditions like lung cancer or like stroke, where you do need to know that these tools are working reliably?
One of my questions, and I love this point about accuracy and validation. And I think it's one of the things I hear all the time about AI, right? Like AI changes, right? The models drift, they learn from things, there's bias. But at the same time, I always think, yes, but in the absence of using these models, what are we doing? We're relying on like an individual human's perception. Like, so how do you know what I mean? Like if a doctor, they see a patient, they become biased in their own way from the population that they're seeing, right? All of the error and omission things that have you've experienced before can happen. And so how do we balance the idea that we're getting performance characteristics, let's say, or we're worried about bias in a model versus the fact that the entire world is biased about everything itself? Like how do we communicate that understanding to someone who might be, let's say, on the medical committee at a large institution?
Yeah, I feel like it's such a common question of one, fear that AI is going to replace the doctor, combined with fear that the AI is not going to be good enough going to hurt patients. It's kind of both sides of the spectrum end up being concerns that prevent adoption. And that's a reality in healthcare. Unless you solve all the concerns for all the stakeholders, the default's going to be inaction. The analogy that I love to use is from the realm of medical errors, which is the Swiss cheese model, where if you are looking for medication errors, it is the role of the doctor, it is the role of the nurse, it is the role of the pharmacist. And on top of all those individuals whose job it is, you also have EHR alerts that need to be plugged in. But guess what? Medication errors post EHR is much lower than it was before, even with all those different layers that already existed. So technology is a completely orthogonal way to address and to start bridging some of these problems. And the thing with it is we're operating in an increasingly bankrupt healthcare system. And so we cannot afford to have more layers of Swiss cheese, more individuals. They're reviewing medical records, looking at images twice. The only way we can actually solve these things is with AI.
I mean, I couldn't agree with you more. It's like we don't have enough hospitals, we don't have enough doctors, we don't have enough nurses, we don't have enough like we just don't have the resources. And it's not like, we're going to magically build, 5 new hospitals here in the Bay Area like next year, next month. It's just not going to happen. We're not going to put more, trainees through medical school, or we're not going to suddenly have a massive increase in the support and administrative staff. And so kind of what does that leave us with? It leaves us with AI. As you and Ferrum Health look at kind of your portfolio of partners that you work with, how do you think about this idea of performance characterization, right? And I assume because you have a number of different groups that you work with, you see, maybe not some as better or worse than others, but as being different, right? In one perspective to another, the bias issue there, everyone's going to have some flavor. How do you try to communicate those differences across your portfolio of partners?
In some senses, we actually stay out of the conversation. I think that there is a rapid expansion of AI models that are available. Individual use cases become increasingly competitive over time. And it really isn't the role of a governance platform that helps hospitals vet and deploy these solutions to also be the gatekeeper for them to try new solutions. The reality is that 80% of all models that are on the market perform significantly worse in the real world than they do in their FDA clearance. So the reality is most AI models do not work to the same degree that they claim to. So we're kind of living in a world where it's not really a question of how do you pick which AI model is the least bad. It's more how do you give hospitals the ability to look at all these tools where they know they're going to underperform in certain areas, but deploy them safely, knowing that underperformance. So maybe an AI model for fracture doesn't work well on pediatric patients. That's fine, but you need to know that upfront so that you can actually make the right decisions on where you are going to use it, where you aren't. So we think of AI as one, a governance process. So you need to have complete transparency and visibility into not just the technical performance of these tools. Are they running? Are they erroring out? Right? Are they taking forever to return? Matters, but much more important is clinical and business governance. Right? What are the impacts of these tools on populations? Are they biased? Do they result in downstream workflow impacts that are positive, driving productivity, or negative, slowing docs down? Those are the sorts of questions that actually cause the large majority of AI tools to not work or to cause patient harm. The second piece is the fact that AI is a life cycle. And so even when you know that a certain tool works, guess what? You're going to replace 20% of your AI solutions every single year as AI evolves. Half of the pilots that you launch on AI are just not going to be accepted by your clinicians. And so there's just an incredibly high failure and churn rate with these AI models that mean that if you're always spending $250,000, $300,000 to turn on every new solution, in a world where half don't work, in a world where 1 in 5 changes every year, you're dealing with just unsustainable technology costs. So AI governance is more of a lifestyle than it is a single solution, where I think hospital systems that are currently thinking of AI as point solutions and turning on a lung tool here and the breast tool here and a stroke tool here, they are solving point solution problems, but they're actually running into a very rapid quagmire of just multi-million-dollar AI support costs that rapidly ends up being the reason why they can no longer progress. And I think that's where most hospitals are today. They've tried AI, they've deployed 1 or 2 solutions, they've kind of run out of budget, and they're kind of sitting there to be like, okay, well, what do I do with the next 999 that are out there?
Yeah, it's interesting. I see and I hear hospital executives feeling kind of overwhelmed on the amount of choice, almost to the point where there's like an AI for everything, but we just don't know how to put that into place. As you were talking, it made me think of one of the interesting questions I always like to ask people, which is when an AI makes a decision or draws your attention to something, let's say it's helping to guide clinical decision making, when there's a medical error, then even though the AI was involved, who's responsible? Is the AI responsible? Is the clinician responsible? I feel it's a little bit like the self-driving car problem, right? Which is, if a self-driving car, your Waymo hits somebody, like who's responsible? Is it the person who ran out in the street? Is it Waymo? Is it like who and how do we have accountability? Does that come up in your discussions?
It comes up all the time. And I think that healthcare has actually solved this through credentialing. So we always know whose license is on the line when a decision doesn't happen, right? It's doctors, it's nurses. And AI is no different. I think there is a view that fully autonomous AI, when deployed into healthcare, is going to run into these governance issues, or these sort of credentialing issues. But the reality is that there are millions of lives to save without ever touching on the credentialing, whose liability, whose risk is it? Like just by making doctors more productive, just by serving as a safety net for errors, just by more accurately measuring lesion growth over time. There's so many use cases where the output is delivered directly to the doctor or to the caregiver, and that's where it ends. And so I think of the 1,000 plus AI solutions that have been FDA cleared for the market, 0 of them are autonomous AI.
Right. Yep.
And
No, I
all
agree.
1,000 of them, the provider is very clearly the ultimate decision maker, which actually reinforces the need to have these sorts of supervision, governance, and transparency into model performance. Because guess what? Like if you don't, it's the provider on the line, it's their malpractice, it's their legal, and they are just not going to adopt it because you're right. It is safer for them to just operate as a status quo than it is for them to deploy an AI tool that the physicians have false trust in.
Yeah. Yeah. Human in the loop requires explainable AI. Absolutely. Um, y- you know, in kind of going a little bit further down this, I think the AI resource issue kind of falls into like three camps. I was talking with someone earlier today about this. Like the three big areas that I see AI impacting healthcare are routine informational based activities. So think of this as when people use the healthcare system and it's important to the individual, but the care or service that they're receiving is actually it's like super routine. It's like you're receiving education and you're asking somebody the same question they've heard 1,000 times before, right? And it's important to you and it needs to be personalized, right? And you need to feel good about it, but you're the resource that's providing you that education could be better used elsewhere. That's like one block. There's another block, which is I think where you're operating, which is in increasing efficiency, right? Which is there are all sorts of tasks across healthcare where AI could make it faster, better, cheaper, more accurate, like all of this improvement in quality. And then there's a last block, which I think is really interesting, particularly in the context of the idea of bias, right? And that last block in my mind is the block that talks about how do we optimize resource utilization, meaning if I have a resource, right, I would like to use it to its greatest benefit. Therefore, I want to select, right, based on opportunity to help individuals. Do you see those types of applications where people are deciding like, hey, you know what? These are the right type of patients to use AI for because it works well. And you talked a little bit about this before when you talked about, fracture in pediatrics versus not. Are those type of protocols being understood and implemented at these hospital systems?
It's a great question. And I think all three of those use cases, and I'll mention one last one, which is improved patient care.
Yeah,
And
that
that's
one.
the one that underlies all of these, of course. But I think AI has a role in all three of them and more. And so I think to some degree, when generative AI started entering the market and you started to basically be able to synthesize, prioritize, automate vast swaths of structured and unstructured information, imaging, labs, EHR, clinician reports, summarization of patient records. I mean, pretty much 80% of all data in healthcare could be synthesized and summarized. You could shorten the patient record by 80, 90% in almost every case and lose almost no clinically valuable information. So there ultimately comes a data problem where healthcare data is one of the fastest growing things in the world. Providers are not getting any better at reading it. Like the average radiologist is reading 15 times more pixels than they were 10 years ago. They don't have 15 times as many eyes. They just have to do a worse and worse job on those images. And you're just kind of seeing the standard of care decline over time as data becomes harder and harder to deal with. That is the fundamental issue. It's taking the massive amount of healthcare data and extracting insights from them that only AI can. And those insights are used in all those you mentioned. But that governance issue, that productivity issue, like these are all just secondary knock-ons. And I don't think there's a way to really bucket AI anymore into any one of those buckets because your AI governance doesn't really care which one it is. You kind of need a systemic approach towards all the models you're deploying as an organization, not just for your admin tools or for your clinical tools or for your productivity tools. Like there needs to be a unified end-to-end, single platform, single pane of glass view of all of the AI that's running in your system, whatever the use case is.
Yeah. It's interesting. I think in Xcares, what we think a lot about is information retrieval, right? And how do we do accurate information retrieval in the context of some particular setting? Because without context, it doesn't matter at all. Let's change direction here a little bit. Let's talk a little bit about the cloud versus on-prem. One of the things that always strikes me in healthcare is we're still looking at on-premises compute, right, in a large number of institutions. I can't imagine another industry. I'm sure they're out there that still does a lot of that. But can hospitals really trust these AI algorithms and the cloud and infrastructure with the sensitive patient data? Because a lot of people worry about PHI
Yeah.
and it goes beyond the worries around simply breach or HIPAA violations. I think it goes down to what are we actually exposing
Yeah.
to these systems?
It's a great question. And it's one that I think we've solved in most other secure industries. So if you're in finance or you're in defense, you're not really even contemplating solutions that are shipping your sensitive corporate data or government data out to vendor clouds. So I think the better delineation than cloud versus on-prem is client versus vendor. Like, are these AI tools running within a client-controlled environment, so in a hospital's data center or a hospital's cloud? Or are they running within a vendor environment, right? The developer's cloud or the developer's data center? That's the more important distinction, because that distinction determines where patient data is. It could be in Azure or AWS, and if it's in the hospital's AWS, guess what? They don't care. Like, there's no additional risk versus if it's in their data center. I think the challenge with AI is that almost every single AI model on the market operates within the vendor's cloud or data center. It operates within the vendor's environment. And every single hospital system that you talk to vastly prefers that the AI run within their environment. So there's a fundamental disconnect in how hospitals want to buy technology. They want models that can be downloaded like an app on your iPhone into their data center or into their cloud, run within their firewall, adjacent to their information, and present no risk exposure. And vendors all want it to run in their cloud, and they want the data, and they want the access, and guess what? When they're given the access, they end up breaching it. They end up secretly using it to retrain their models. They end up with all these issues that arise. And like it or not, in healthcare, the solutions that succeed are going to be the ones that the hospitals decide to adopt, which means that hospitals are increasingly looking to platforms that can take those models that are currently in the model cloud and download and deploy them within the hospital's private environment, whether that's any one of the hyperscalers that the hospital is using, whether that's hospital's data center. I think that's a missing layer of compute, right? Like, who's going to own and manage the GPUs in that client environment? It's not going to be the vendors. It's not going to be the hospitals. And so that's the missing layer, is the actual AI application environment, that middleware layer that's actually connecting the AI to compute, connecting that to the patient data, connecting it to the interfaces that the doctors and clinicians are using, and supervising and governing all of that. Like, none of that is going to exist outside of the hospital's firewall, outside of their cloud or their data center, which means you need all of that middleware running in a hospital somehow. And that was one of the insights that we had when we started Ferrum was, wow, like, nobody's going to be able to do this. The hospitals sure as heck aren't. There are some great examples where they're starting to, Mayo Clinic, Mass General Brigham. There are some folks that are, but 99% of health systems are never going to be able to build the sort of orchestration and integration engines that need to exist to support these tools. And they're also never going to be comfortable sending data to the vendor's cloud. So there needs to be a middleware. That technical orchestration and governance is where we started. And then we actually expanded from there into clinical and business governance as these tools became more widely adopted.
I find the problem, I've never thought about it that way. So that's a completely new way for me of thinking about it, of in the vendor's cloud versus in the hospital's cloud. Don't you run into issues, though, thinking about this now from the AI supplier's perspective, of the fact that your models are actually continuously changing? I've run into this before, where healthcare providers or systems say, you can use our data and run compute on it, but you can't use our data to train your model. And you go, well, wait a minute, I'm doing AI. It's continuously, like, every time I use it, it trains. And in fact, the value that's provided is this continuous training and updating and all of the fuzziness that comes with that. But that's actually what ensures that we're performing correctly and that we're adapting this technology to. It's no different. I was thinking of agentic AI. It's no different than an employee, right? You might work in one hospital and they go work in the other hospital, but they bring all the experience that they have with them. So does that dialogue come up of the whole difference between in the firewall versus out of the firewall and the actual benefits of being there? Or is it truly just the security issue overwhelms the pros and cons of both approaches?
Take that same argument and try it on the Department of Defense, or try it on a financial services firm. It's dead in the water. Combine that with the fact that unless we dramatically change how the FDA governs clinical software, these AI models can't continuously improve. Every time you change a single model, but you've got to resubmit it to the FDA. And we can change that, but that requires an act of Congress that redefines what FDA does. And so that's not likely to happen in the coming years. So we're kind of stuck. We're kind of stuck with this world where we can only deploy AI if we meet the security requirements. Regulators don't actually permit many of these AI tools to improve. And so they're not going to be adopted unless you actually deploy in a way hospitals and regulators want you to. In the agentic world, there is a change, but you know what the biggest concern is that these hospitals have? Is that these model developers are going to use this, and suddenly all of a health system's coding and billing data is going to be de-identified, aggregated, and made available to Optum to now analyze the market and do more work on. So what does it mean to de-identify? What does it mean to aggregate? How do you actually ensure that a patient record, a social security number, a diagnosis of cancer, is going to be de-identified in a way that doesn't harm the system? It's not possible. So I feel like, just like other secure industries, vendors have been trying to use this talk track for since AI was invented, and it just has never worked, and it's not going to work. The last thought on this I'll mention is, while the only option was Anthropic and OpenAI and some of these massive foundation models that only sold via API, sure, you had no other choices. But DeepSeek, Llama 3, you're seeing all of these new models that are essentially equivalently performant, that are open source, can be fine-tuned to your local population, can be run locally on your own compute, can power all of these agentic workflows without any risk to patient data, with full control over your data provenance, with no security. Like, so if you talk about where the future of AI is going to go, even with agentic AI, guess what? Far greater benefits to being able to fine-tune an AI model on my own data than some abstract aggregate benefit of an AI model benefiting from all of the different stakeholders that are involved.
I think we're going to see more of this idea of multi-tenant secure architecture, right? Where it takes a certain amount of expertise, to your point around the middleware, to deploy software, right? And to essentially make it part of, you got to bring it into the firewall, but where's the firewall? You know, the firewall used to be like a physical server, right? A firewall, what's firewall in the cloud? Well, it's the compartmentalization of the data and the security layers that sit around it. And so I think the big question becomes like, what goes in and out of these different firewall sections, and how do we manage it? It's interesting what you talk about with the FDA, because I do think the FDA really struggles with the idea of continually adaptive algorithms. You know, we had discussions with them, I did certainly years ago, and they just understood why that could be really important and valuable, but did not have a regulatory mechanism that would enable them to regulate something that, you know, didn't essentially have code branches along the way. Where, like, why would you do code branches? We're AI developers. We don't believe in that, right? Like, let's just keep adapting. So again, let's take another question here. How do you think AI now is actually going to affect the physician and the physician's workflow? So if I'm thinking about, you know, the tools that your company is starting to layer into the platform, are you starting to see them change and have a real impact on clinicians' workflow and caseload, et cetera?
Yeah. So I go back to this idea that 80% of healthcare data is just unnecessary. And it's figuring out which 20% matters. That really is the key. Similarly, like Pareto principle, 80% of what a clinician or a nurse or a caretaker does is unnecessary, has nothing to do with optimizing patient care outcomes. And so we exist in a world where there are just such massive inefficiencies. Even something as simple as making a lung cancer diagnosis requires comparison to previous charts, review of previous records, looking at the lesion itself, determining how it compares to other data points within the patient record. So even a simple assessment can require combing through minutes and minutes and minutes of data that an AI could do in the snap of a finger. So I think that we exist in a world where there are massive workflow inefficiencies. There's a massive workforce shortage. And the way that we're addressing that is by pushing clinicians to generate more and more RVUs over time. And the thing that goes to the wayside is quality. So the question becomes, well, we're not going to change healthcare reimbursement. We're going to keep paying less for them to do more. And we're going to keep turning a blind eye to how that affects the quality of patient care because we have no other choice. So I think it's a bit of an arbitrary dichotomy between, is AI for quality? Is it for productivity? Is it for efficiency? Like, it's essentially just to keep moving patients through the process at the level of care that they need to receive. And everything else is kind of gravy. So That is to say, every AI tool that we see in the market, even if it has only purely quality impacts to the provider workflow, that quality impact actually leads to provider productivity. And we see that all the time.
Yeah, it's interesting. I always think of, when you're making the business case argument to someone, which I do all day long, I'm sure you do too, and talking about your business, I always like to focus on, hey, I'm going to help you make more money, right? Because for any system that's under pressure, that's actually what they care about. So you go and talk to the administration. The question is like, how many RBUs can we generate? Like, what's the amount of revenue delta that we can expect to receive from this? And it always strikes me that we don't do a good enough job of quantifying that sometimes into something that's a concrete number in terms of revenue impact. And that isn't to say that patient quality and care isn't really important, but that's often what I think at the top level gets the ball rolling. And then to your point about gravy, the efficiency gain and quality gains that sit underneath that actually end up being realized. But it takes a long time, like a quality gain, right? Or an efficiency gain actually requires a fair amount of time to understand and to really take advantage of, versus the revenue gain on the top end. So, are there any examples you can think of or that you've seen where you're actually seeing something like an RVU volume go up, right, because of the implementation of AI?
Yeah, I mean, more than you can throw a stick at. And a lot of AIs in radiology, it's in diagnostic imaging. That just happens to be where AI has been the most mature for the longest. A lot of these agentic models operate in care coordination, patient communication, some of these other areas where there are just a ton of staff. But pretty much all of the models that we see out there have some sort of impact either to clinician confidence that leads to downstream productivity, or literally just saving clinicians time for every record that they are having to go through. But I think the other component of this that is really underrecognized is the fact that it's not even about, is AI adding value? Because almost every system at this point has a long and growing list of AI models that they've already determined add value. They already know that they need to deploy stroke AI, or that they need to deploy fracture AI, or that their x-rays are being read to insufficient quality by their Nighthawk radiologists. So like, they already have AI solutions that they've determined are valuable that they need to deploy. And the reason why they're not actually recognizing the value is because it's going to cost them $500,000 for each vendor to turn on. And so there's a organizational cost to turning AI on that actually oftentimes is an order of magnitude greater than the AI model itself. So for a $50,000 tool, a health system might spend $300,000 to turn on year one and $100,000 to maintain it years 2 onwards. So that's the cost that we think is actually the real barrier to AI adoption now. I haven't met a system or a provider that doesn't have a list of AI tools that they want to use. Now they may ask, hey, like, I need to determine whether this AI tool actually delivers on the value it's going to give me, which is why I need the intelligence and the Tableau dashboards and the sort of reporting on the AI model that I can't do myself. But that is actually not the driver for most of the interaction today in AI.
So at Ferrum, are you guys able to, you talked a little bit about orchestration, like when your clients come on and they use your platform, are they able to just basically bring new models on through a very clear process? Like, how does that work?
Yeah, it takes us an average of 2-3 weeks to onboard a new vendor. You can think of it like Apple publishing a new app to the App Store. Those applications are all packaged and conform to the Ferrum standard architecture. From there, they can be deployed upon shared compute that is in any hyperscaler or hospital data center. And they can be integrated into their current systems, not in a one-to-one manner where every AI model needs to have a copy of all the patient data sent to it from every interface and data repository, but a single integration into the EHR, into PACS, into the data warehouse that can be used to power all these different AI tools. And then a single integration back into the interfaces, the clinician workflows, the reporting systems that AI results need to fall into, so that you're not dealing with a exponentially increasing number of integrations and endpoints for a linear number of AI applications, but you're dealing with a single unified integration environment, compute environment, and interface for these tools that's being governed by a single application developer portal, a single pane of glass view of the clinical and business insights, and ultimately an ability to replace and update these models over time. And what we see is 20% of AI models get replaced any given year, and probably more than that if it weren't for vendor lock-in. And that number is significantly higher than EHRs or existing healthcare systems. So I think there is a real, just fundamental difference with AI being adopted today versus any other solution.
How do you find the PACS system vendors and the EHR vendors? And in some ways, you're coming into a world where, to your point about vendor lock-in, they are kind of locked in many cases. And they view that as a strategic part of their business, right? Is the ability for them to provide and manage data on behalf of their health system clients. How do they view this ecosystem as it changes?
The EHR PACS vendors, the market incumbents, are not in a position of technical competency to be able to build the sort of modern, hybrid, cloud neutral, automated AI orchestration and governance systems that need to exist for this market to work. They are in control of the interfaces. And so we don't claim to or want to compete with the folks that currently own the eyeballs of the doctors. We think that the role of AI is in deciding and helping prioritize what gets into those interfaces, but that those interfaces are kind of baked in and they're kind of not a very fun place to play in. Like, I don't want to be competing with Epic on building an EHR. I don't want to be competing with Nuance on building reporting systems. I just want to make sure that all the AI tools that should be running on that data and then being fed into those interfaces is operating appropriately and efficiently. So they're going to keep having the marketplaces. They're going to keep owning the interfaces. There might be some disruption there, but our role is on the AI application side. And we're actually a catalyst and enabler for most of the players that are currently in that space. And AWS is going to sell a hell of a lot more compute with Ferrum running on it than they would without. Right? So that's how we think about the market. I think it is the great enabler for AI that lifts all boats. And Epic's going to keep charging their App Orchard fee, and that's great. They're going to make a lot more money the more applications you flow through that. And that's going to happen because of us.
Wonderful. Well, Pelu, this has been a fantastic conversation. And by the way, I couldn't be more excited that you guys are helping bring AI into this marketplace, especially in a way that's scalable, right? And is going to address, I think, many of these concerns that you and I have been talking about today. So thank you again for coming on the show. Really loved the conversation with you. And I know we're going to be keeping in touch in the future.
Really enjoyed it as well. Thanks so much, Mika.